You've woken up from a long post-call nap on Friday with a craving for tacos. Tacos from La Taqueria, to be specific. It's the best taco shop in town, but it's 20 minutes away. There's a new neighborhood taco truck 5 minutes from your apartment. It's not yet rated. La Taqueria has a rating of 9 out of 10. You weigh your options, think about all the other stuff you have to get done, and settle on the nearby taco truck. It's probably not better than your longtime fave, but likely good enough for what you need. That scenario that you just went through, it's the basis of non-inferiority trials. You've been designing them and faithfully calculating acceptable non-inferiority margins your whole life. It's about trade-offs. Are you willing to go with something that might be not quite as good, but for some other reason? It's close by. It's still a good choice for you. In the same way, you can see how a new drug that is more convenient to take, say an oral pill instead of an injection, and is effective enough, would be acceptable. There are other reasons why a new treatment could be considered good enough. It could be cheaper or have fewer side effects than the current standard. When you look at the whole package, the new drug is close enough to the old standby. You don't need it to be better. You just need it to be not much worse. So, how do we define not much worse? In a clinical non-inferiority trial, this is what is known as the non-inferiority margin. Let's talk through an example. Let's say IV antibiotics for 6 weeks is the standard treatment for osteomyelitis. The IV regimen has excellent efficacy, but it's inconvenient. You have to stay in the hospital for a long time or get discharged with a big IV line in place. Oral antibiotics would be much easier to take, and even if they had a slightly lower efficacy, they would be worth it for some patients. To determine an acceptable non-inferiority margin, you review the literature and discuss the case with infectious disease experts. Together, you decide that less than a 5 percentage point treatment failure difference would be sufficient to use oral compared to IV antibiotics. When the trial is completed, you compare this margin to the upper bound of the 95% confidence interval for the difference in the percent failure calculation for the two treatments. If the upper bound of the 95% confidence interval for the difference in treatment responses is 5 percentage points or less, the oral treatment is considered non-inferior to the IV treatment. If the upper bound for the difference in responses is greater than 5 percentage points, oral treatment will be considered to have failed to meet our non-inferiority expectations. That is, it is not non-inferior. All this stats talk making you hungry? Our friend too. They look pretty happy with their choice. When you're both hungry and busy, a taco in your hand is better than 2 far away.